You can see I'm extra excited today to have Dr. Kelley Hutchins with us. She's one of the hematologist oncologists at Kapiolani, and she'll be bringing in our little month of hematology oncology conversations. Um, you know, anemia in general is always a topic I can particularly use refreshers on. And as we've been seeing quite a lot of alpha thalassemia um, traits and variations thereof, I am looking forward to learning more. I will pass it on to Dr. Hutchins, and will be available in the chat. Feel free to add any questions you have, or you can always unmute yourself and join the conversation. Thank you.
Thank you. Thank you, Anna and Summer, very much for introductions and inviting me today, and for everyone who's joining. And I'll go ahead and share screen if that works. So yes, again, today I'm going to review thalassemia and do a focus towards the end on management of some of the major types that we see. Again, I have nothing to disclose. Briefly, again, the objectives describing the thalassemia spectrum, being able to interpret laboratory results among patients who have thalassemia and being able to differentiate among those who don't, to describe various treatment options for patients and knowing who may need, who doesn't need, and what types of therapies are available. And then to identify patients who might develop complications as a result of their diagnosis, as well as some of the treatments that they receive. So just some questions to think about as we go through, and then we'll go through them at the end. But the first is true or false, thalassemia is a common blood condition. True or false, patients with thalassemia can have iron deficiency. Treatment for patients with thalassemia may include which of the following: packed red blood cell transfusions, iron chelation, psychosocial support, or all of the above. And number 4, patients with thalassemia may develop which of the following complications: skeletal abnormalities, iron overload, splenomegaly, or all of the above. So just briefly going over a brief overview of thalassemia in general. So this is a very common inherited blood disorder of hemoglobin synthesis. It is one of the most common single or monogenic diseases that exist. And depending, and I'll go into more detail in future slides, the prevalence can be quite high. Most importantly, this is going to be alpha or beta thalassemia, which is a decrease in your alpha globin chains or your beta globin chains, respectively. So kind of back to some basics about hemoglobin. So in the normal adult hemoglobin, our primary hemoglobin is hemoglobin A, and this is composed of your alpha and your beta globin chains, and you inherit these from your parents, of course. So each parent will give you 2 alpha genes and 1 beta gene. So that's why you see two chains for the alpha and then 1 for the beta. Genes for the alpha and then 1 for the beta. The normal predominant fetal hemoglobin is our hemoglobin F, and this is composed of alpha and gamma chains. And you have 2 alpha chains from each, and then get 2 gamma chains from each parent. And what you see is over time, the gamma chains will transition into the beta globin chains, and we'll talk about that in future slides as well. There's also a minor hemoglobin, which I didn't list here, is the hemoglobin A2, and that's composed of your alpha and your delta chains. Most people are familiar with the newborn screen, and so what you'll see when there is a defective production of the alpha chains, this can lead to an abnormal excess amount of gamma chains, which leads to what's called hemoglobin BARTs. So the gamma chains collect and they form these tetramers, and that is hemoglobin BARTs. The essential counterpart of that is hemoglobin H in adults, and it's these gamma chains that have become the beta chains, and now the hemoglobin BARTs is essentially your hemoglobin H. And these are unstable hemoglobins that are not effective. They bind oxygen they have a high affinity for oxygen. And the problem is then it has poor oxygen delivery to tissues, which causes some of the complications and the problems that can be associated with thalassemia. This is and all the references are at the end, and this is I like this photo because it kind of goes back to how these chains evolve over time. And so the main site of hematopoiesis changes from prenatal to postnatal. So initially, this is all taking place in the yolk sac, and at the very beginning, you have what's called your um, zeta chains, which become your alpha chains, and then these epsilon, which become your gamma, which over time switch to become your beta. So as you can see, the alpha chains are predominant, or they're almost always from the time of conception, whereas your beta chains don't become predominant until postnatally. So that's why at birth, you still see the hemoglobin F, which again is composed of your alpha chains and your gamma chains as your predominant hemoglobin. Whereas as time goes on, you get the switch where the gamma become the beta chains. And so then your hemoglobin A becomes the predominant hemoglobin. And then here you can see the delta, which will combine with the alpha, and that becomes your minor adult hemoglobin, or the hemoglobin A2. And it's interesting because the mutations, and I'll go into more, but there are essentially are hundreds of mutations, and depending on the type of mutation, it can happen really along any trajectory of this time. And so some people might have miscarriages earlier in life if they have more severe mutations or mutations that present earlier, whereas others might not present until later in the prenatal time frame. For example, patients who have what's called the Filipino cis mutation, predominant in Filipinos, where they have two mutations, or two deletions, this specific mutation that can present earlier in life if it's co-inherited from the mom and the dad. Whereas patients of Southeast Asian, for example, their mutation presents earlier, later, and the clinical manifestations wouldn't happen until a later prenatal time, if that kind of makes sense. And I'll go through a little bit more, but it's cool just to see how things transition over time. So prevalence. So again, kind of alluding to this. So this is extremely common worldwide. It's estimated that approximately 5% of the world is at least a carrier of an alpha thal variant. And this is very variable depending on the ethnic group or the area of the world. This is protective against malaria, and so it's highly prevalent, particularly in the tropical regions, the subtropical regions, and it can reach as high as 40% in certain countries, again, Southeast Asian countries, Mediterranean, and there's reports of even up to 90% to almost 100% in places such as Nepal, where it's just almost everyone has a variant of this. Not necessarily that they have clinical manifestations or that it's dangerous or harmful for the individual, but just that it's very prevalent in a carrier state. And then with epidemiologic transitions and migration, so this transition where people are living longer and dying of different things than previous, where it used to be maybe communicable diseases and has transitioned to things more like heart disease and cancers, the prevalence is also increasing. And with population migration, where people are moving and relocating, Southeast Asians, immigration into California, Hawaii, Australia, people of India, or going to Northern Europe. And it's becoming much more prevalent all around the world. So not just location anymore, of course, but just knowing that this really does exist everywhere. So I'd mentioned genotypes and phenotypes. So the genotypes, so there are literally hundreds of genetic mutations for both the alpha and the alpha thalassemias combined. So again, depending on the type, the severity correlates to the clinical manifestations of the patients. This ranges from being totally asymptomatic, patients who might have just one or two alpha gene deletions or mutations, to essentially fatal in utero, depending on the severity, if they have a 4-gene deletion. And again, the severity is usually going to correlate to the number of non-functional or mutated functional genes for the alpha globin, the alpha as well as the beta chains. So for this, screening and prevention. So screening has become pretty much a universal, I don't want to say mandate, but essentially a universal recommendation from the obstetrician and gynecology, one of their national consortiums, to essentially screen all pregnant women with at least a CBC. So CBC, and what you're going to be looking for is microcytosis and or anemia. If there's nothing detected, but there's still concern given the potential, given the ethnicity of the family or family history, for example, thalassemia is known or patients are quote unquote anemic and haven't been worked up, then they might pursue further testing in those patients as well, regardless of the result of the CBC. And this would be in the form of starting with a hemoglobin electrophoresis, which can sometimes differentiate with the beta and or alpha. And then ultimately doing testing on a fetus once a patient is pregnant, if that's something that families elect to pursue. Fetuses can be tested via chorionic villus sampling or amniocentesis, and essentially the earlier the better. Should families want to have to so that they could be aware of the severity of the condition for the fetus. And it's, again, important to do this, especially for high risk couples. If patients are 100% Filipino or 100% Italian, these as examples, these patients are at higher risk of being carriers of more mutations, which can ultimately lead to more severe presentation of the child, which I'll show you in the next slide as well. And then counseling is really important so that patients can be aware of the potential manifestations that could occur depending on what degree of thalassemia these patients have, how many genes are mutated, if a patient's going to have, if a pregnant lady is going to have a fetus with, say, 4 gene deletion, what kind of things could they expect and what are their options? And I'll get into that too, because that's also evolved over time. 4 genes used to universally be a diagnosis where these infants would always die in utero or shortly thereafter. But now there are potential treatment options for patients depending on the location of the patient and child. And so it's just really important to, advocate and make people be aware of their options, not only for the baby, but also for the pregnant lady themselves. So for your patients that come to you, right? So like you're saying, Anna, you see these patients a lot and they might come and be quote unquote anemic or have a microcytosis. And sometimes it's on a routine check or you're looking for something else and you happen to find it. Some of these patients present to you with an abnormal newborn screen. So it really is going to just be dependent on the clinical situation. So if you have a newborn and you're presented with a healthy full-term newborn who has hemoglobin BARTs detected on a newborn screen, it's important to talk about the family history. How, is it known that patients have thalassemia? Because hemoglobin BARTs on a newborn screen is very supportive of a diagnosis of thalassemia. It does not tell you the degree or how many genes are deleted or mutated, but getting a good history from the family saying, oh, none of us have any problems, or, oh, I've had my spleen taken out, or, oh, I get transfused every month, can kind of can correlate to how the child will do. But in general, when patients are born, have an abnormal newborn screen, it's almost never going to be an urgency or emergency to do significant workup in the immediate time period. Sometimes patients will present a little later in life. And again, it's just going to be dependent on, kind of what's happening. So if you have a 3-year-old come in and they're tired all the time, they're yellow, they're not growing well, you get a CBC, that's going to be your next step. But you want to talk about, have they ever been jaundiced? Have they ever needed blood transfusion? Again, talking about the family history. Is there any known history of thalassemia? Asking about the ethnicity, where the ancestry lines are. Doing a good physical exam of the patient. A lot of these patients, again, depending on the state, the carrier state, how many genes are mutated or deleted. Some patients will be totally asymptomatic, but patients who might have more more severe disease, and perhaps they haven't been treated, for example, some patients can present with skeletal abnormalities because of this ineffective erythropoiesis that can develop, where you can start to get frontal bossing, which is basically expansion of your forehead bone, like the bones of your skull or of your face. Patients can develop splenomegaly over time. They can have signs of being anemic, so looking pale, or a little jaundiced. So if any of these things are happening in your patients, and if there's other questions about this later, then you're going to, go on to your laboratory evaluation. And the first thing, again, is looking, do these patients have a newborn screen, depending on where a patient was born, and seeing if hemoglobin Bart's was detected. Hemoglobin Bart's is not always present, and especially in a carrier state, which is a single gene deletion for alpha thalassemia, it often won't be. So it's not 100% reliable. But if it's present, again, it's very supportive of a diagnosis of alpha thalassemia. And then eventually you'd get a CBC. Now, again, this is not an urgency in the first few months of life, in almost all children. But eventually, you would get a CBC, and you'd look at the hemoglobin, hematocrit, and then the red blood cell indices. And these patients are going to have, depending again on the degree, some might have a degree of microcytosis and hypochromia, which is where you have a low MCH, which is the hemoglobin concentration within the cells. And this is something that, we talk about in going through your training, is the Menser index. This is a nice little screening to kind of differentiate between iron deficiency, which is often mistaken in little kiddos with thalassemia, to thalassemia. So it's your MCV. So if you can think about a patient who has an MCV, a low MCV of 60, and an RBC count. A kiddo with iron deficiency might have a red cell count of 2, whereas a patient with thalassemia has a normal red cell count because they're making their cells would be higher, say of 5 or 6. And so a low Menser index is more consistent with thalassemia, and typically 13 is about the cutoff. And then a higher one is going to be more consistent with iron deficiency. And again, this is not 100% confirmatory, and you can have overlap where you can have both together. And that's also going to be important in your questioning, because you do want to know other things. Could there be a concomitant other problem? And that's where you get to your additional testing to make sure you're ruling out other problems. So one is always looking at a blood smear. We're hematologists, so we like to look at the smear. Sometimes you'll see, for patients with thalassemia, you might see target cells. You're going to see what's called anisopoikilocytosis, so different sizes and shapes of cells. If you do what's called a supravital stain, which is not a routine test, at least that we order, you can sometimes see the actual inclusion bodies of the hemoglobin H. It forms what's called these inclusion bodies, and you can see it on the stain. And then in patients who have more so the beta thal, you might see the basophilic stippling. Whereas in iron deficiency, you might actually have patients who have thrombocytosis as a reactive finding. So you could also see, in addition to, being hyperchromic, microcytic, you're going to see, you might see thrombocytosis or increased platelet count. So you want to rule out other causes for microcytosis. So iron studies is super common, right? Iron deficiency. But you could have a two-year-old kiddo with thalassemia who also drinks a gallon of milk a day. So you can have two things at once. So it is important to rule it out, because although down the road, these kiddos, some of them are at risk of increased iron overload, they could also have this as well. Or say a teenager with Crohn's or inflammatory bowel. So again, just to make sure, you don't want to give them iron unnecessarily, but just to know it's a potential. Checking a blood level, just to make sure. And then I put reticulocyte count in a bili because it can kind of see the degree of hemolysis that is going along with the anemia, or if there is a degree of hemolysis. And then checking a hemoglobin electrophoresis. So hemoglobin electrophoresis is, we do this routinely here. It can help with both alpha and beta thal. So in beta thalassemia, because you're going to see an elevated hemoglobin A2. And that's because the hemoglobin A2, going back to the other slide, is made up of your alpha and your delta. And so when your beta chains are decreased, you're going to have a decrease in your hemoglobin A, which is your alpha beta. but you'll see a rise in your A2, which is your alpha delta. And you might also see a rise in hemoglobin F as well, comparatively. So that is very supportive if you have a patient with microcytic anemia and you have an elevated A2 on your hemoglobin electrophoresis. That is very consistent with the diagnosis of beta thalassemia. In terms of hemoglobin H, so which is 3 gene deletion for alpha thal, and I haven't shown that slide yet, but it's the next slide I'll show you. If you have patients who have 3 gene deletions or 3 gene non-deletional 3 gene mutation, then you can also see a hemoglobin H on your electrophoresis as well. So it can be helpful for that too. You may not, though, if you have a single gene or if you're a carrier state, have any changes on your hemoglobin electrophoresis for patients with milder forms of alpha thalassemia. And so when possible, genetic testing is often used for confirmation. Now, it's very recognized that this is not available in all countries. And so in low and middle income countries, it's still very routine to use things such as the newborn screen and the CBC and history and physical. Whereas if you have the option to do genetic testing, this can actually give you the specific genes, whatever the specific mutation is. And we try hard to get off for this. And there was actually a program here with the genetics where they had a grant and were doing this for patients and their families for confirmation. And so this is just kind of going over the genetics of alpha thalassemia. So we said, so there's 2, this is on chromosome 16, you get 2 genes from mom and 2 from dad. And then normal is you have them all. The carrier state, again, is when you have 1 missing. So this is asymptomatic patients. They don't have any problems. It's really just to be aware of because they could present with a very mild microcytosis, but again, they're asymptomatic, don't require treatment. But it could be mistaken, rarely, but maybe for an iron deficient state if you have a little bit of a microcytosis. So just being aware that you have it could be important. This usually wouldn't present until later in life or when people are checking for something else. The next one is alpha thalassemia minor or trait, and this is where you have 2 gene deletion. So this can either be on the same chromosome from one parent, which is your cis, and you can see that down below where both are missing, or trans, where one is missing from each parent. This is more common. The trans is more common in patients from of African ancestry, whereas the ones with the cis is more common from, for example, Southeast Asian countries. And then hemoglobin H, which we all have heard of, is often sometimes symptomatic, but sometimes not, and sometimes these patients can go throughout life, and again, not even realize that they have this until being picked up for some other reason that they had a blood work done. But again, it is going to vary on the mutation. So up here, you'll see there is non-deletional, which is this. So here is where there's 3 deleted, hemoglobin H, and this is actually often less symptomatic than patients who have the non-deletional form of hemoglobin H. The most well-known is hemoglobin constant spring. And again, this is fairly prevalent in patients of Southeast ancestry, and we do see this here. And these patients can present where they are in need more often of blood transfusions, iron chelation, and have more complications than patients with hemoglobin H, who often, again, rarely require intervention. And then historically lethal, considered historically to be lethal, is hemoglobin Bart's hydrops fatalis when you have all 4 gene deletions. And then for beta thalassemia. So also historically, this was categorized as minor, intermediate, and major. And minor was essentially where you had 1 normal beta gene and the other was mutated. Intermediate, where you have 2 that are mutated, and major, where both are also mutated, but the mutation itself leads to a more severe clinical form of beta thalassemia. But now it's more recognized whether patients are transfusion dependent versus non-transfusion dependent. So instead of categorizing as mild, intermediate, or major, often it's whether patients are actually transfusion dependent and non-transfusion dependent. And patients who are transfusion dependent will often present very early in life sometimes as early as 4 to 6 months once that transition period from the hemoglobin F to the hemoglobin A occurs. This can be seen in little babies who say are, just severely anemic early in life. It might be the first presentation. And this, again, is how patients are categorized going forward, transfusion dependent and not transfusion dependent. So then management, and I'll go into more detail in the next slides for this as well. But again, this is going to be, as I kind of alluded to, is going to be dependent upon the degree of disease. So in regards to alpha thalassemia, patients with just one gene or the silent carrier, or the trait, the two genes, whether it's cis or trans, are almost always asymptomatic. Even though with trait, you might have a mild anemia. Again, typically these patients, we might do a consult once and then we actually don't see them again. And it's more about counseling for future. And that is important going forward for, again, when they go on to have babies, just to be aware of their state. But again, typically they will be just fine and not require additional therapy. Very rare to require things like red cell transfusions. Hemoglobin H, similar in terms of most do well and are asymptomatic for the majority of their life. Caveat to that is that they are at higher risk of having issues when they have times of extreme illness, for example, and they could have a higher degree of hemolysis that potentially could require periodic transfusions, as well as if they have an insult, things such as oxidative damage and stress. So it is recommended that patients who have hemoglobin H or transfusion-dependent thalassemia, that they avoid oxidative stressors, similarly to patients who have G6PD deficiency, for example, things like sulfas and other medications, as those could potentially exacerbate their anemia. Again, the caveat to that is that hemoglobin constant spring, the non-deletional form, where those patients can have a more severe clinical course where they do require more transfusions and more support, kind of like a patient with transfusion-dependent thalassemia who has beta thalassemia. And then there's hemoglobin Barts, which I'm going to, again, talk about, much more severe, again, historically fatal in utero or shortly thereafter. And this, again, is the 4-gene deletion for alpha thalassemia. And then again, management for beta thalassemia also is dependent upon the degree of the mutations. So in general, these are some of the things that could be used for some of the patients. So transfusion therapy, iron chelation, depending on the degree of iron overload a patient might have from either receiving red cells, or sometimes patients will start to scavenge iron if they do have a severe form, say, of the hemoglobin H non-deletional form, constant spring, say they're not getting transfused, then their GI tract mistakenly starts to scavenge iron. And over time, those patients actually could become iron overloaded and require iron chelation. Folic acid, potentially, patients who have severe hemolysis or if they are transfusion dependent, it's recommended, kind of plus minus in a otherwise healthy patient with hemoglobin H who has a low retic count and is otherwise thriving as long as they're eating well-balanced diet. It's not a necessity to have to supplement this, but some may. Times of pregnancy, if these patients are pregnant, we do this anyways, but it's also recommended that that would be an indication to replete with folic acid. Or if there are times when patients are actively going through like a hemolytic crisis, then potentially considering an extra course of folic acid as well. Hydroxyurea could be used as an adjunct, and kind of like with sickle cell, the point is to drive up your hemoglobin F. I have personally not used this, but it is listed as one of the potential things you could consider. Splenectomy is typically reserved. This is going to be reserved for patients who develop either massive splenomegaly from extramedullary hematopoiesis. They have just rapid cell turnover and it enlarges because of the severity of their of the hemolysis from their thalassemia. But it's not ideal to do, and especially not in little ones who are unvaccinated. And when you do take out the spleen, it's also been shown that patients who have it taken out with hemoglobin H are higher risk of thrombosis. So it's not without a lot of thought if you're going to do this. And then stem cell transplant is something that is curative for some patients when indicated. So when do we transfuse? So who do we transfuse? So again, all these patients, you're not going to need to transfuse all these patients. And again, most of patients with thalassemia variants, the state is going to be a milder form. Patients who are living less than 7, you want to transfuse them because, again, they're going to develop other problems that come along with being chronically anemic. Those patients who are less than 7, you want to transfuse them to get their hemoglobin up, ideally between 9 and 10.5, which could require transfusions as frequently as every 2 to 5 weeks, depending, again, on the severity of their thalassemia. And the hope for this is that you're going to decrease both the extramedullary hematopoiesis that could happen in the liver, as well as the ineffective erythropoiesis that happens within the patient's own bones. And that, again, is the thing that can lead to the expansion of the bones, which can be both dysmorphic and painful. So again, you want to drive up the hemoglobin to decrease the ineffective production of the body. Other times, if patients aren't growing well, if you already notice patients have bone pathology, or if the anemia is, say they live at 8, 8.5, and they're just tired all the time, it's affecting their work, they have headaches constantly. So those could be other indications as well. And so then just some relatively new-ish updates in some of the management options. So one is intrauterine transfusion. So this is done for patients who have 4-gene deletion, similarly to patients who have had, for example, RH isoimmunization. If these patients are detected early enough in utero, then there are institutions where they are able to provide intrauterine transfusions to basically save these babies. Again, this is important to discuss what this means before doing so and with the family, because for these patients who had this historically fatal hydrops fatalis or 4-gene deletion, who now are able to survive into postnatal life, it will be they will require chronic forever transfusions or a definitive therapy such as stem cell transplant. But it is really interesting and cool, and for those who are able to do this, if this is something that families choose to do. Luspatercept is a medication that's been recently approved for patients who have beta thalassemia. And this is a sub-Q injection that's given every 3 weeks. And this helps drive the hemoglobin of the patient up to try to avoid and decrease the frequency of transfusions those patients get. So this is approved and this is being utilized and has been shown to be effective. Gene therapy, also very interesting, very expensive, not available everywhere. Some is still in trial, but has been ongoing. And there were some articles published, which I'll talk about a little bit later, for beta thalassemia currently. And then in trial as well is intrauterine stem cell transplant. So this is being done in California for patients who have that 4-gene deletion, where they're doing the intrauterine transfusions, and they're also trying to transplant maternal stem cells into the fetus in utero, which is pretty exciting. So these 2 articles came out, and one is a consensus statement back in 2021, and these were regarding the management of patients with alpha thal major or the 4-gene deletion. And again, going back to, this used to be a fatal disease, and now for some, when possible, again, depending on resources, patient wishes, etc., potentially can live into normal childhood. There are not adults, to my knowledge, yet who have received these therapies, but definitely many patients have received intrauterine transfusions with the 4-gene and have survived. And even here in Hawaii, I know that there's at least 1 or 2. These are some of the articles regarding gene therapy for beta thal, which is kind of cool for anyone who's interested. So back in 2018, they published on a gene that was using a lentivirus, as well as more recently a CRISPR-Cas9. So there have these different kind of gene therapies that are available as curative options for patients currently with beta thalassemia, and still undergoing study as well. And so what are some of the complications that can occur? We've talked about many of these throughout. And again, it's going to depend very much on the patient. So many, say most, will not experience these complications, especially if they have the trait or if they're a silent carrier, and again, even many with hemoglobin H. But depending again on the severity of the mutation, transfusion-dependent thal, hemoglobin H constant spring, over time, these patients are at risk of splenomegaly, iron overload requiring chelation, various endocrinopathies often associated with the iron overload, the skeletal abnormalities that we talked about. Some can go on to develop cardiac complications, again, more predominant in your transfused patients or patients with the more severe anemia, liver disease, and then this can be psychologically distressing for these patients too. They have to come to clinic frequently if they're getting transfused. Some patients, again, are short-statured or have, dysmorphologies depending on where they are, what they have, etc. And so again, can be psychologically distressing, and important to try to connect families with each other and with patient advocacy groups if and whenever possible. So I just wanted to go over a case presentation for a kiddo who was referred to me. This was an 8-year-old Filipino male who came for microcytic anemia. He was referred essentially just for consultation. He came with his father and his paternal uncle. And it was done via translator, and he knew one of his blood counts was low. He said that this was just done for a screening lab because they just moved from the Philippines. He had been taking iron supplements for a few months. He said he didn't miss any doses, and he's otherwise been very healthy throughout his lifetime. He was born full term in the Philippines. The only thing he had was tonsillitis. He did take antibiotics. He didn't know which kind, but he had no problems with them. He had never been transfused, and he eats, he says, everything, but not a lot of quantity, and only drinks about 2 cups of milk per day. His development is normal, and again, he's only taking ferrous sulfate. For his family history, there is no known anemia or thalassemia that they're aware of. And again, they recently moved here with dad, and the mom, they're still together, but was living in the Philippines. He had no history of jaundice, did again well with some unknown type of antibiotics. He's not had any increased fatigue, sweating, no pallor, he's never yellow. He plays basketball with his friends, says he naps occasionally, but for him this is normal. Denies any headaches, easy bruising or bleeding or other complaints. So his height, 125 centimeters, 22 kilos. This was small, like on the growth curve that we use, small for his age, but he was well appearing. He did not have any abnormal facies or frontal bossing appreciated, no lymphadenopathy. I did not appreciate any murmurs. He did not have any splenomegaly, and had no significant pallor. So on his labs, white count was normal, platelet count was normal. He had a microcytic anemia. His hemoglobin was 9.5 with an MCV of about 54. Elevated RBC count, almost 6. And a corrected reticulocyte count within essentially the normal range. So he didn't appear to be actively hemolyzing. So corrected of 2.5. This is not his smear, this is taken from an article, but peripheral smear of a patient with hemoglobin H. So there is some microcytosis and hypochromia, but otherwise, and I mean, I'm looking now, there's no white cells, but that's not part of this. The platelets are normal. And then this whole anisopoikilocytosis. So aniso, different sizes, and then poikilo, different shapes you can see throughout. His ferritin was normal, as were his iron studies. His hemoglobin electrophoresis was normal, and his lead level was less than 2. we were able to get gene testing for this patient, and he did in fact have a he had 3 gene deletion. So he had this heterozygous HBA2 deletion with 1 gene that was deleted, this 3.7 kilobases, which is a very common mutation. And then he was had the 2 gene deletion for the Southeast Asian. And this is consistent with a diagnosis of hemoglobin H. So with that, I was just going to go over the questions, if that's okay, real quickly. So thalassemia, do you guys put these up or should I just go through them?
Yeah, I can launch the poll.
Oh, okay, it's a poll. Great, sorry.
Oh, great.
Have to see if we know the answers first. Thank you for such quick to read, no double negative questions. I find coming up with questions really challenging and then making
yeah.
in a way that it's not a huge stressor on the brain is really a lot harder than you would think, right?
Yeah.
Yeah, after seeing all these post-session questions, some of the questions are tricky.
Mhm.
But looks like everyone is great. There's no big discrepancy on or any variant on any question. So I don't think we have to review them. Everyone's
Okay. Yes, good. Yes, everyone. Thank you. Yeah, for knowing those. So yeah, so those were, you guys all did a good job with those. Thank you. And so I have the references in the back, and yeah, happy to answer any questions or if anyone has any thoughts or comments or anything. And thank you again so much for having me and for everyone for being here today.
Oh, thank you so much for joining us again. It's always a pleasure. I see one question currently in the chat, ultimately asking if a normal newborn screen then reassures you that there's no thalassemia in the patient.
Yeah, good question. So no, not totally. So if you're a silent carrier, again, 1 gene for alpha thalassemia, you could be a silent carrier and have you'll be asymptomatic, but you still could have that with a normal newborn screen. And then you could still have a form of beta thalassemia for sure. So this often won't come up on your newborn screen, again, because your beta predominantly will switch with your your adult hemoglobin will switch with your fetal hemoglobin later in life, meaning your gamma chains will switch to your beta chains later in life. So that doesn't present right away on the newborn screen. Unless it's a very severe form. So you can have a suspicion of beta thal if it's a severe form. But if you have a beta thal trait, for example, then you won't be able to detect that on the newborn screen. So it does not completely rule it out. It's a longer answer to the question, but
I appreciated the explanation though as to why it doesn't show up immediately. It helps me actually remember the answers you give, especially. But I think that's one of the tricky things about the newborn screen. It's meant to be reassuring that at the end of the day, there's always these little caveats behind it, especially with the recent changes. I feel that I see a lot of these kiddos that have likely some form of underlying, whether it's iron deficiency or thalassemia, that just have an underlying lower hemoglobin hematocrit, that though tend to, I find, look a little bit worse when they're with us, obviously, as a hospitalist, when they're admitted. I feel I often see numbers in the 9s that we don't necessarily do anything with because they're stable. And we kind of chalk it up to a combination of everything. And kind of leave it up to the PCP if they want to trend later on. Is that reasonable? Is there anything specific I
Yeah,
could be
no, I totally
recommending
think
the
so. Yeah,
PCP?
no, I think that seems totally reasonable. I do think, ensuring it's not iron deficiency, for example, because iron deficiency in and of itself, which is different talk, but is never technically a diagnosis, right? So you do want to make sure that it's not that. But no, I don't think you have to go looking for like doing the electrophoresis or for sure not sending genetic testing or any of that stuff in the hospital in an acute setting. I think would totally make sense. If you have a patient who's hemolyzing down, and that's a different story. So sometimes we'll get that question where, okay, if they're 5 or 6 and they're actively hemolyzing, you're going to transfuse them. Then you might want to see, what is the baseline hemoglobin electrophoresis before you transfuse red cells. You can always do it later down the road, right? You just have to wait the 3 months where the transfused cells are out of the system. But if you're able to do that, if it's like an acute process, then that's fine. But no, I think if the kid's otherwise stable, they have other things you're treating, then it seems totally reasonable to have that be done in the outpatient setting. Yeah.
Okay.
Yeah.
And then any specific recommendations I can give in regards to they could follow it up in like 3 months after the illness? Is there a certain time frame? Does that?
Yeah, I think it's probably in combination of what is happening. If it's like they have the flu and they're otherwise okay and have them see the pediatrician. You can also leave that more to, I would say, more the outpatient setting. Now for patients people who are on the call who are outpatient, I do think knowing a baseline, right? If you found something abnormal, you do want to kind of see, okay, well, is this where they live? And do you need to do more about it? It's not that everyone's going to need to see a hematologist, but yeah, you want to see, make sure that they're better. I would at least say that they're better, like that they're not still acutely sick, because you can have anemia.
Not trending down,
Right,
or
like
actually hanging in the
right.
nines.
Yeah, inflammation on top of the thalassemia too. So that's always a tricky thing, right? When you do have something else happening in addition to the underlying genetic problem. But I don't know if that helps you at all.
It does.
Okay.
Thank you. Yeah, no, and it is often tricky because yeah, I feel like I'm making these discussions and then kind of decisions and then kind of putting it on the PCP, but I also hate not having a more concrete plan to give them. But yeah, I think, like you said, following up ultimately once the acute inflammatory process has calmed down.
Yeah. No, I would support that.
Haven't seen any other questions come through yet. I feel like I can keep asking a bunch of questions that are slightly hospitalist related, but I'm trying to also make them a little bit outpatient. If anyone has questions, feel free to add them. Otherwise, I might follow up on one other question that is not necessarily thalassemia, but you did mention it. The dropping hemoglobin in the hospital. Often we kind of chalk up to frequent blood draws. How, I guess, how certain or how much can you expect it to drop with blood draws? And then again, how is this, they'll then again be kind of, I see 9 a lot, 9 point whatever. They'll again be like 9 or 10. And then we sent them home with kind of this new low. Should we be sending them home with iron to like just kind of supplement and kind of help bring their hemoglobin back up? And then should the PCPs kind of follow up on that as well?
Sure. No, that's also a good question. So the thing with iron, so if they're in the setting like an infection, for example, if you're seeing them for an infection, then I would not necessarily recommend. The thought is like with iron, and I can't quote you anything, but like, are you feeding infection by giving iron? There's thought about potentially that, or like avoiding it at least in the acute illness. So, I think once the patient's getting better, they're going to start to recover their bone marrow. So we do see this, anemia of inflammation, which can be anemia of acute inflammation, not just chronic. You always hear about chronic, but really anemia of inflammation, both acutely and chronically. So I think really it's more just the clinical context in terms of like how much you drop them by drawing every day. If you're drawing on a baby versus a 10-year-old, you know, are you taking 1 tube, 10 tubes? It's kind of variable, you know, but it's not uncommon to see a gram drop every couple days, you know, or even every day, depending on how much you're taking or the clinical context and you're giving them fluid. So, I mean, yeah, so it's, you know, I think as long as it's, you know, in coordination with primary care provider, if you have an unreliable family, that's a different story too, right? But I think just as long as you're getting a good, you know, handoff with the primary care and they're able to see and do an exam and make sure that they're clinically stable, I don't think you have to supplement iron when they go home. I would not say so, just because you're drawing blood, if that makes sense.
Absolutely. No, and I think we just really love blaming the PICU when that's anemic, which obviously, like you said, really is more a combination of the acute illness since they're coming much sicker from the PICU.
Yeah, often multifactorial, right? I know that's like the catch-all phrase, but things are sometimes just multifactorial and like, yeah, you have to.
Sometimes it really just is
Sometimes,
what
yeah.
it is, and then
Yeah.
that's okay as well.
Yeah.
Oh, well, thank you so much. Okay, everyone, last chance to add a question or two. Otherwise, I will let everyone go a few minutes early, which I'm sure everyone appreciates as well. Thank you so much again. I can talk about heme topics, honestly, I feel like all day. Dr. Hutchins will confirm I love to bug her in the middle of work.
No,
So
you're lovely.
thank you so much again. That was excellent. I'm seeing thank yous in the chat as well. Great presentation, absolutely. We're happy to have you back again. Thank you so much for joining us. And then we will be continuing onwards with our next topic, which will be oncology. We're gonna have Dr. Tristan Knight coming back. He did residency at Kapiolani and is now joining us from Seattle. He's going to be talking about thriving after a transplant, the pediatrician's role following bone marrow transplantation. Oh, and then I just closed it before I saw the date. Shoot.
September 4th.
Thank you. On September 4th. So thank you, everyone. And thank you so much again, Kelley.
Thank you guys very much.
Bye,
Thank
everyone.
Thank you.
Thanks, Anna.
Bye.
Dr. Hutchins, PDF is on iEcho if you folks want to access that as well. So mahalo, everyone.
Excellent. Thank you. Thank you.
Thank you all. Thank you.